You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Welcome back to Just Medicine. My name is Zoe, and I'm a second-year medical student at the University of British Columbia. I will be your host today. I'm very excited to announce our special guest, Dr. Victoria Weaver. I will give a quick bio before we head into our discussion today. Dr. Victoria Weaver is an adult infectious diseases and addiction medicine physician in Vancouver, BC, and a clinical assistant professor in the Department of Medicine at the University of British Columbia. She trained in internal medicine at the University of Calgary before completing her adult infectious diseases fellowship and addiction medicine training at the University of British Columbia. She currently works as an adult ID physician at Vancouver General Hospital and as an addiction medicine physician at St. Paul's Hospital. She is one of the first doctors in Canada to be dually trained in both addictions medicine and infectious diseases, and I'm very excited to have her on the podcast today. Thank you so much, Dr. Weaver, for joining us on the Just Medicine podcast today. I'm really looking forward to hearing some of your unique perspective, and I think today our main topic is really going to be focused on the intersection between addictions medicine and infectious disease, which is, as mentioned in the bio, exactly where Dr. Weaver's expertise is. So thank you so much, Dr. Weaver. Welcome.
Oh, thanks for having me. It's really nice to join you.
Yeah. So I guess just to start off, I think starting off broad, can you maybe just tell us a little bit about your background and the path that you took to get where you are today?
Yeah, so I don't know how far back you want, but I did med school in Hamilton at McMaster, and then went to do my core internal medicine training in Calgary, matched to infectious diseases here in Vancouver, and then did my clinical infectious disease fellowship here for 2 years. And while I was doing that, I'd always kind of been interested in addiction medicine, and was a little bit sad to choose, have to choose between the two. And I had reached out to the addiction medicine fellowship when I was an ID fellow, and they hadn't trained anybody from infectious diseases before, but they agreed to let me come for an elective, and I was able to train with them. And now I split my time between being an adult infectious disease doc at VGH, and that includes both inpatient and outpatient services, and then doing addiction medicine at St. Paul's. Again, both kind of inpatient and outpatient, and then I get to do a little bit of work in the community as well.
Right. And so could you just tell us sort of what a typical day in your life as a dual infectious disease and addictions medicine specialist would look like?
Yeah, so I don't always get to combine both skill sets. So there are some things where it's just, pure infectious diseases and seeing, all of the things involved with that, surgical infections or bone and joint infections. And then there's some days that are, more addiction medicine focused, depending on where I am. But more and more lately, I get to kind of combine both of them. And so a typical day, depends on if I'm inpatient or outpatient. But it might look like being in the rapid access addiction clinic at St. Paul's and seeing folks there for any number of substance use sort of concerns that they have. And we see all kinds of substances, or being part of the inpatient consult team for ID at VGH. It kind of depends, it's nice to have that flexibility and that variation. So you never get bored of anything or tired of any one thing.
And was there anything that specifically drew you towards either of these specialties? Like, what was it that really made you interested in addictions medicine and then infectious disease as well?
I mean, I think infectious diseases is just the coolest. There is, I would say, no other specialty where you can say it has shaped the course of human history. Like, infections have, shaped all of human history, from like things like the Black Plague to tuberculosis, more recently like the COVID-19 pandemic. Entire societies are different because of infections, and I think that's so fascinating. And then at the same time, you can't really talk about infections without talking about people who are the most affected by them and the most disproportionately affected by them. Historically, infections are more prevalent and more common in those with lower socioeconomic status, in those who are, systemically disenfranchised. We know that most infections, follow poverty. And so you kind of can't be interested in one without being interested in the other. And unfortunately, in Canada and North America in general, oftentimes that poverty and that sort of, injustice is hugely overlapping with substance use. The people experiencing some of the greatest rates of poverty and, the greatest health inequity are also experiencing the most disproportionate harms of substance use. And I think when I was an infectious disease fellow in particular, we would see folks coming back to hospital over and over, or to things like OPAT, with just the same infections. And, as a trainee, you find that frustrating. You're like, oh, why is this person back here? But a huge, component of infectious disease practice is the idea of source control. So, if you have a belly full of pus, you've got to drain the pus. And I think, in chatting with patients and other, members of the care team, I started to think more about managing substance use as a form of source control. If we can address this in a better way and in a less siloed fashion than it currently is, we might be able to help people have better health outcomes when it comes to infections.
Yeah, that's such an interesting way of looking at it. I've never thought about it that way, but it makes so much sense that, you can't it's like treating the symptoms of the problem without actually treating the problem itself. So, kind of along those lines, what specific challenges do you, as someone working in this field, do you think that individuals with substance use disorders or people struggling with addiction face in accessing healthcare for infectious disease?
And I've had the opportunity to listen to previous episodes of your podcast. And, you've certainly talked before about how the hospital isn't always the safest place for folks. We're not always practicing the most trauma-informed version of care. And so certainly for, folks who are experiencing symptoms that would otherwise send someone to hospital, things like, fever or, significant wounds or pain in certain places, a lot of folks would go to hospital when they experience those things. But if you've had truly traumatic experiences in the hospital, it may be, difficult to present there. Certainly lots of people wouldn't want to. And so we often see people coming when their infections are, at a much later stage than we would otherwise want them to be. And then on the other kind of end of that, when folks are in an inpatient setting in particular, a lot of the way that we treat infections, which involves often like multiple dosing of antibiotics throughout the day, lots of tests, lots of follow-up, basically being on our schedule in the hospital, that might not work for everyone. And so it's not infrequently the case that people will choose to leave hospital before all of the tests are done or before all the treatment is completed, because it's a frustrating place to be. And we may not always do the best job of explaining kind of the rationale behind what we're doing. And when they leave, whether that's, at the end of their treatment or before that, sometimes getting folks to come back for follow-up can also be a challenge. If you are worried about finding a place to sleep or finding food to eat or shoes to wear, it may be harder to keep track of like, what day is my appointment? Where is my follow-up? What labs do I have to do before that? And so I think folks face significant challenges at every step of the journey along the way.
Yeah, and so again, about that sort of treatment pathway, is there ways that the hospital tailors treatment regimens to allow for this population to have better access to those treatments?
Sometimes, and I think we're getting better at it. So there's a lot of emerging evidence for things like use of partial oral antibiotic treatment courses, for some bacterial infections like endocarditis or osteomyelitis. The historical treatment is 4 to 6 weeks of IV antibiotics. And for folks with substance use, that's often completed in the hospital. And I couldn't imagine living in the hospital for 6 weeks. But, more and more as the evidence accumulates, I think we're slowly becoming a bit more comfortable with using oral regimens for some folks. I think trying to use wherever we can, less frequent dosing of antibiotics, or try to really think about, is this test necessary? Is it going to change my treatment? Does this person really need it? I think that can be helpful. And then in some places, so in St. Paul's in particular, which is where, like I mentioned, I work part of the time, just having like peer navigators and people with lived and living experience to be able to sort of, help folks through that and help to meet their needs and making sure that we're addressing some of those substance use needs.
And so, just to give our audience and me as well a bit more of a broader idea of what we're looking at, can you touch on which particular infectious diseases are more prevalent or pose unique challenges within populations with concurrent substance use disorders?
Yeah, so you probably can't think of an infection, I'm trying to think of one that isn't more common in someone with substance use. So, when we break it down, we can think of like bacterial infections. So certain bacterial infections are certainly more common, ranging all the way from like skin and soft tissue infections to, things like endocarditis, osteomyelitis, epidural or vertebral abscesses. I think underappreciate dental infections. And so, it's difficult to access dental care in Canada at the best of times. And so folks certainly experience a lot of dental infections, viral infections. So HIV and Hep C are the two really big ones that we think about as, being more prevalent in folks who use substances. And then sexually transmitted infections are also quite significant. We have seen a huge rise over the last 10 years in Canada in the rates of infectious syphilis. And a large amount of that has been attributed both in Canada and the US to increasing rates of substance use. And so, certainly, I think all infections, which is why I think that the overlap of the two specialties is, so complementary and so nice to practice at the intersection of.
Can you touch on, from your perspective, why the increased substance use in America and Canada has caused that increased rate of syphilis?
Yeah, I think there's lots of reasons that have been postulated. In particular, one of the things you'll see cited is increased rates of syphilis among particularly the gay bisexual men who have sex with men community. If they're sometimes using stimulants to enhance the effects or the experience of sex. But we also know that rates are rising more in people who identify as heterosexual and specifically heterosexually identified women. And that has been variably attributed to things like participation in survival sex work in order to, be able to consistently have access to substances, which we know, those two things go hand in hand. And of course, the risk with that is then we've seen a rise in congenital syphilis as well.
Mm. Right. Yeah, I can see where those concepts intertwine. It's a huge public health issue. I've been reading some articles on syphilis, and it's definitely on the rise. Going more broadly now, from your point of view, what are the strategies or interventions that you have found that have been most effective in addressing the medical and social needs of individuals with co-occurring substance use disorders and infectious disease?
Yeah, I think in part it depends on where you're seeing folks and what you're seeing them for. The approach to treating someone who has maybe chronic hepatitis C is probably pretty different than an acute endocarditis. But in kind of all cases, I think the most important thing is we talk a lot about shared decision making. We get taught a lot about it. And I think that should, but doesn't always extend to our folks with substance use disorders. Folks often have a lot of experience. They know people who've had a lot of experience with various infections. And so just as best as we can, having frank conversations with our patients of what do you know about this? Have people you know or love gone through this? What are your expectations? What are you afraid of? How can we help to mitigate that? In particular, in the inpatient setting, we know that under-addressed cravings and withdrawal are one of the number one reasons that people leave hospital prior to completing therapy for infections. And so wherever possible, trying to address that, whether that's, offering replacement therapies in the case of things like opioid use disorder, offering opioid agonist therapies, or, managing other symptoms of withdrawal to keep folks comfortable and to keep them, make it easier for them to stay in the hospital.
Mhm.
Similarly, in the outpatient setting, the idea just of meeting people where they're at. If I'm seeing someone in clinic and my goal is to treat your hepatitis C, that might not necessarily be your goal, and kind of working with folks to make sure that we can get on the same page, and remembering that at the end of the day, like, we're there for patients, and all we can, or the best we can do really is try to make sure they know that if our goals don't align, we can try to keep them safe, and we'll be here for them if they change their mind.
With caring for these patients, when you encounter sort of confidentiality concerns and also the stigma associated with both infectious diseases and um, substance use, what is your approach to that? How do you navigate that as a specialist in these areas?
Yeah, sometimes it's a little tricky. I imagine you're probably thinking about things like HIV or something in particular.
HIV and any sexually transmitted disorder. I think substance use in general, we know there's huge stigma and huge repercussions from that, and in terms of mental health, physical health, emotional well-being, and as someone who's constantly helping these patients, how does that affect your practice?
Yeah, in terms of the confidentiality concerns, I think always starting off up front with what are the limits of confidentiality, which is really everything that is shared between a provider and a patient is confidential, with a few exceptions of concern about their safety or the safety of others. And then really making sure that the setting for any of those conversations is correct, whether you're talking about substance use or you're talking about infections. I think there was a lecture recently in, I think it was Med 412, where one of the speakers who had some lived and living experience was saying that someone came into her room unannounced and said, "I'm here to talk about your HIV," but they were there with friends and family members who didn't necessarily know that they had HIV. And so, really, really making sure to sort of check in with folks that you're taking care of, who is it okay to have with you when we're talking about some of these things, who is it not okay to have, and making sure that we afford the same privacy and respect and protection that you would afford anybody. And certainly, in some settings that can be difficult. In the emergency, we just have those little curtains, and they're certainly not soundproof. But then considering, like, maybe that's not the time for a confidential or a sensitive discussion, and instead of saying, like, I'm here to talk about your opioid use disorder, speaking in more general terms of, how could I help you be more comfortable right now? Or, can we chat about some other things, like questions that we ask everybody, or kind of even framing why you're asking the questions that you're asking, because oftentimes we know that folks tend to anchor their questions. You see someone, when maybe you read through the chart before you see them, and you develop an idea in their mind or in your mind of why they're here, and you kind of approach the encounter in that way, and that might not pertain to that patient. And I think coming into those encounters with preconceived notions, which we totally all do, but just sort of reminding yourself of, everyone's going to be a little bit different, and we're not serving ourselves well, and we're not serving our patients well if we're coming into those patient encounters just assuming, like, oh, they're here for drugs, or I think often doing that, making those assumptions, we can miss things. We sometimes attribute to drug use or drug withdrawal things that could be explained by other processes, and by not thinking harder or digging a little bit deeper, I think we can do some serious harms.
I can totally imagine that would be really difficult to deal with. We know we've learned a lot about trauma-informed care and sort of approaching everyone, as if they have gone through many things that we have no idea about. And I think that's probably just, a part of it. But it is still very difficult, because I think all of us are prone to forming ideas about people within, like, before we even see them, and then when we see them within a few seconds. So yeah, it's very important as healthcare providers, for sure. So I just want to touch a bit more on sort of preventative measures. What specific screening protocols or preventative measures do you typically recommend for your patients with substance use disorders to mitigate their risk of actually acquiring infectious diseases?
Yeah, I mean, I think it's important to sort of separate recommendations for acquiring infections and then also recommendations for screening.
Mm-hmm.
In terms of acquisition, I try to do, no matter which hat I'm wearing or which place I'm working at, a lot of harm reduction counseling. So counseling around safer injection or safer smoking practices, trying to ensure that if necessary, folks have access to sterile supplies for injecting or smoking or however they're using, what substances they use, talking about things. And, folks who use drugs like know these things. They know them better than any of us ever could. But really making sure that they have access to the things they need to put their knowledge into action and keep themselves safe.
Mm-hmm.
So I think that's one of the big first steps is, these things can help prevent the acquisition of infections. And so how can I help you access them?
Mm-hmm.
And then also, like you had mentioned, screening. So I think every healthcare encounter is a great opportunity to offer screening. If we're doing blood tests, you're doing a CBC or creatinine or whatever, it's also a good time to screen for standard, sexually transmitted and bloodborne diseases. So things like HIV, syphilis, viral hepatitis. Overall, we're really good, I think, at screening for HIV. Lots of folks have like multiple HIV tests every year. I think one of the next steps, especially in light of rising syphilis rates, is to start training ourselves to, every time we're ordering HIV, order syphilis testing or thinking about ordering syphilis testing. And also chatting with our patients about what that means, particularly if those results come back, showing that they do have an infection and what does that mean, and making sure that folks have their questions answered and they understand that. And I do have, which I can send you, just sort of a little kind of table of, best infectious practices for people who use substances.
Mm-hmm.
So about screening, thinking about, every healthcare encounter as an opportunity to offer things like vaccinations, as an opportunity to discuss things like harm reduction or PrEP, pre-exposure prophylaxis for HIV, for those who kind of meet the criteria for that. I think those are some of the biggest things.
Yeah. I just want to go back to what you said about, sort of making sure that people who use drugs are able to access, cleaner materials and things that are going to keep them safe while they still use. Do you know what programs we have specifically in BC? Is there any programs that we have that support that?
Yeah, in terms of legislation, I'll be honest, I'm not sure off the top of my head. I will say lots of clinics, particularly clinics in the downtown east side, have sterile supply kits. Certainly St. Paul's Hospital, there's an overdose prevention site on the 4th floor. And like I said, we have peer colleagues who are part of our team who, anybody who's being seen by addiction medicine, or even folks who maybe decline to be seen by addiction medicine, can be connected with some of those peer colleagues, just for access to things like the overdose prevention site or sterile supplies if they're using. And then in community, I did recently hear about a website that folks can order sterile supplies from. I think that's probably a little bit higher barrier because obviously you have to have access to a website, which suggests use of a phone or computer, which not everyone has. And then I think you have a mailing address for things to be sent to. I will admit that my knowledge is largely restricted to the Lower Mainland. And so I know that access to some of these supplies is certainly perhaps more difficult in more rural or northern parts of the province. But I can also reach out to colleagues who work in those areas for their knowledge and get back to you on that too.
Yeah, great. Yeah, I'd just definitely like to hear kind of more just as a practical, especially for, incoming med students, so that we know, what exactly we're dealing with, if someone is asking about that and what's available. So it's great to hear about that. Um, So I want to touch a bit more on your personal experience with your sort of unique training. So how do you think um, having your expertise in both the addiction medicine and infectious diseases actually enhances patient care? And do you think it enhances their outcomes, particularly for those people who are, you know, coming in with both of those sort of problems going on?
Yeah, I mean, I'm probably a little biased in that I do think it enhances their care and their outcomes. There's also good objective data to back that up.
Hmm.
Um, there's plenty of studies that suggest that when we co-locate addiction and infection treatment, that people do better in terms of both their substance use and their infections. And that kind of makes sense in that, if you can address two problems in one place with one team, that is easier than doing it in multiple places with multiple people. In terms of how, on a more day-to-day basis, I think it allows for more frank conversations in terms of, how did you get this infection? What does that look like? And then I also think having the training and the experience in addiction medicine definitely gives me a better understanding of like, what are the potential places and conditions that people are coming from or being discharged to? What resources do they have access to? Like, what might their life look like on a day-to-day basis? And I think that allows for a greater understanding of like, does the treatment course that I'm recommending make sense for them?
Hmm.
So for someone that you're seeing in the OPAD or the emergency department with a skin and soft tissue infection, if you're housed and you're working and you can set alarms on your phone, then maybe a 3 or 4 times a day oral medication is a great option for you. But if you're not housed and you are living in a different place each day and maybe not able to get reliable, safe sleep, or you can't access food reliably, then maybe that's not the best person to be giving a QID Keflex prescription to. And I think, being able to understand where people are coming from and where they might be going to helps to make better choices that are going to work for them and hopefully set them up for better success.
Hmm. Yeah, and when you're helping these patients, can you tell us what other healthcare professionals in general do you tend to collaborate with the most to provide comprehensive care?
Yeah, it depends a little bit on the setting. Certainly nurses, social workers, outreach teams, especially when you're trying to make sure that you're optimizing someone's outpatient plan. Um, I think, when we're in the hospital, it's sometimes the most helpful thing is if someone's followed by an outreach team or an intensive case management team. We're only seeing patients for a very small fraction of time in the hospital, and being able to reach out to those teams and community and get a better understanding of, what is this person like when they're not unwell and in the hospital, and what might work for them, I think is helpful. And then I think far and away, I've mentioned our peer colleagues multiple times, but I think in both the inpatient and the outpatient setting, they are some of the most valuable healthcare workers to work with. Because I think, as much as when you're chatting with patients, you say, oh, I know how you feel. Like, we don't. Obviously everyone in medicine has come from a different place and a different background. But a large percentage of us don't actually know what it's like to be unhoused, and we don't actually know necessarily what it's like to have those experiences, and to have someone working as part of your team who's like, no, I actually do know, and I do remember when I had that, and here's what was helpful for me, I think is incredibly valuable and widely underutilized.
So are those intensive care teams that you mentioned and those outreach teams, are they only at certain hospitals? Like how common are those teams? And I've never actually heard about them, so maybe just touch on that a little bit more.
Yeah, their community outreach teams are fairly common through the lower mainland, and some folks who maybe need a bit more support in different areas of their life will often have case managers, or even just a primary care provider who's familiar with them on a more longitudinal basis. So in Vancouver, there's the STOP team for folks who have HIV. There's OOT, which is the overdose outreach team, and they're wonderful. They can, help people to make their appointments or ensure that they're able to get to the pharmacy. And I know that exists as well. The Sunshine Coast has a version called SCOOT, which is the Sunshine Coast overdose outreach team. And then there's some intense case management teams, which are often nursing driven, and they work within the communities that folks live in and kind of quite literally meet them where they are at. And they're amazing. They really advocate for patients. They know them so well on both a personal and professional level. Often they're able to do things like wound care, blood work, and help folks make it to primary care appointments or other appointments. And I think for anybody who is followed by teams like that, it's incredibly valuable to be able to reach out to them and like I said, get a sense of what is this person like in a more holistic sense, because none of us are our best selves when we're admitted to hospital and feeling poorly. And then also get a sense of how can I make a plan that will work for them or that their team can help them with.
Yeah, that sounds really helpful, and definitely we'll look into that a little bit more. I feel like we've got a good sort of idea of how, the day-to-day works and what collaborations you have and all of that. So maybe could you just tell us anecdotally, what are some unique emotional or ethical dilemmas you have encountered when providing care to patients?
Yeah, I think in addictions medicine, we definitely come up against a lot of ethical dilemmas. Some that come to mind are for folks with infective endocarditis that's related to injection drug use. There's often a lot of discussion and a lot of, ethical discussion around things like surgeries, specifically like valve repair or valve replacement surgeries. And often the folks experiencing those bouts of endocarditis are otherwise folks who are young without a lot of medical comorbidities who would otherwise be very good surgical candidates. And so, from our perspective on the addiction medicine or the infectious diseases side, it can feel really important to advocate that they get surgery if it's otherwise indicated. And certainly, the ethics of valve replacement surgeries or even things like transplant surgeries come up not infrequently. And I find that those can be very emotionally difficult cases. Especially, I consider myself still youngish. And when those patients are, close to your age or, and someone who's otherwise a near peer, it can be a little hard to not get over invested. That being said, I think that the practice around that is maybe changing. We also see, some of those ethical kind of considerations with things like provision of dialysis for folks who, might be experiencing either temporary or more long-term renal failure. And I think those can be very tricky situations to navigate. And they're definitely rife with emotion.
Yeah, I can imagine. To be clear, so with this sort of ethical dilemma, for example, like the valve replacement surgery, are people who are continuing to use substances, are they at this point in time in BC, are they able to access the valve replacement surgery, or is it very case by case?
It's very case by case. There are, by various cardiac societies, there are specific, high level indications for when someone should be considered for valve surgery. Of course, the concern is that if the underlying infection or underlying sort of substance use rather, isn't addressed, that a new valve could become infected, and then you're dealing with prosthetic valve infective endocarditis, which can be incredibly difficult to treat. So it is on a case by case basis, and there are often multidisciplinary rounds with infectious diseases and addiction medicine and cardiology and cardiac surgery where everyone kind of comes together and tries to talk to one another. And I think historically, and probably until not too recently, or until quite recently rather, it's been the case that, as soon as it's seen that the person has substance use or injection drug use on their chart, it becomes a non-starter and they are not considered. I do think that that's changing. Recent recommendations do suggest a more sort of whole person approach to endocarditis care in particular, and it is a high level recommendation that addiction medicine be involved in the care of people with endocarditis related to injection drug use. At St. Paul's in particular, which again, I'm biased because I work there, but there's a lot of work going on to have a more multidisciplinary approach to this with a group that meets regularly. And, I think there's a real appetite to create a better pathway to, make sure that any treatment or surgical intervention that's being provided is being done so in kind of an equitable fashion. But that's certainly not the case everywhere.
Right. Okay. Thank you for answering that. I know it's definitely difficult to reflect on some of those things. And so, also sort of related to this, in terms of your colleagues, have there been any instances where you might have faced resistance or skepticism from colleagues or the healthcare system, like regarding the importance or validity of people with substance use disorder, and especially correlation with their infections and their care?
Definitely. And so, the idea of dual trained infectious disease and addiction medicine specialists overall, not new. There's several dual training pathways in the States. So there's, Boston University Medical College, Yale. They have offered dual training pathways for a while. There was no one who was formally dual trained in Canada when I applied for addiction medicine, but there were a lot of folks practicing in ID who had kind of picked up addiction medicine on the fly and were, practicing what elements of it they could to try and, take better care of their patients. And so I very distinctly remember, there was a lot of like trepidation, I think, from colleagues. There was one colleague who I really respected who had said, "Oh, it's too bad that you took up a whole infectious disease fellowship spot just to go and prescribe methadone." And that was a really hurtful thing to hear, and I think maybe a bit reductive of, an entire specialty. I think, some of the folks I work with who have been doing addiction medicine for a really long time are some of the most brilliant and empathic people I've ever met, and I don't think you could say that all they do is prescribe methadone. But at the same time, there's now 3 of us that are formally dual trained in Canada. There's 2 of us here in Vancouver, and there's someone else as well in Hamilton. And I think there's more folks who are interested in it. And, interestingly, that colleague who had a disparaging remark has since actually referred people to come and see me. And, we've been able to kind of work together to get the best kind of care that we could for their patients. I think there will always be folks who think it's a bad idea or, good for you, but I'm not interested in doing that. And I think that's okay. I think, if there are folks who aren't interested in making that a part of their practice in infectious diseases, I think that's a-okay. But we've definitely seen, I think, a warming up to it. And that happens anytime something is new. Colleagues I did general internal medicine and then addiction medicine were told the same thing. They were told, like, you did all of that GIM training just to go be an addictions doc. But now addiction medicine is like a very accepted subspecialty training pathway out of general internal medicine. So hopefully, and of course, those are just the things that people have said to me. I don't know what people have said not to me, but I think, like I said, I think folks are warming to it, and they're seeing, especially as the overdose crisis continues, we see increasing amounts of people who are becoming homeless or marginally housed. I think people are beginning to appreciate the need for it, and beginning to respect maybe a little bit more of that dual skill set.
Yeah, for sure. And I think that the need is so clear. And I definitely hope that, over time, that need is clear to everyone. And then the dual training, I just think is such a great combination. And I'm very passionate about this stuff. And it's just great hearing all of your experience and how, it has had such a benefit for so many different patients and so many different people. So yeah, I hope that it just continues to grow. But I have one last question for you. It's a bit sort of more tailored towards med students. So, if you could give us one piece of advice to any medical student who might be going into infectious disease rotations or caring for people who have both an infectious disease and are dealing with substance use, what would that piece of advice be?
I mean, I think it's probably the advice I give to all learners is be kind. And that's like a bit of a cop out, but especially as I think a medical student, when you're on service somewhere, or you're in clinic, maybe less so, no one's expecting you to see 10 patients a day, I hope. And so oftentimes you have the luxury of spending a little bit more time with people, of getting to know them a bit better, of talking to them a bit more. And I think if you approach that as an opportunity, A, to extend kindness to folks, but then B, to be receptive of their stories and appreciate that no one can teach you more about, the experience of or the intersection of substance use and infection than someone who has those things. Like I can talk forever about statistics and graphs and antibiotics and opioid agonist therapy, and I will if you give me the chance. But no one knows it better than someone who has lived it and is currently living it. And so really, being respectful of that, but affording it, the same reverence and the same respect that you would afford any of your lecturers or any of your preceptors on any of your other rotations. In previous episodes, other guests had mentioned that addiction medicine is often seen as a potentially frustrating place to practice medicine. Patients get labeled as like difficult patients. And I think just trying to shift that narrative of like, are they a difficult patient? Are they a hard to reach patient, or are we a hard to reach system? And really remembering that sometimes negative reactions or negative responses to things you do or say are not so much a reflection on you as like the cumulative reflection of someone's experiences with the healthcare system, which you maybe have the opportunity to make better.
Wow, okay, that's great advice. Thank you so much. Do you have anything else that you want to add?
No, I mean, do rotations in ID, do rotations in addictions medicine, be kind, and yeah.
Okay, well, thank you so much for taking the time to speak with our podcast today. And I look forward to having some more discussions about addictions medicine with you, hopefully in the future. Yeah, thank you so much.
Thanks for having me.
Thanks for tuning in to Just Medicine.